So thank you to Anne and for everybody for having me. This is a wonderful opportunity. Did not quite expect the hurricane weather, but living in North Carolina, you learn that you can never expect anything. Just a list of disclosures. So I've been tasked with talking about gender differences in MPNs, and is this something we think about? And so I've had an opportunity to spend time in a basic science lab, and my question always goes back to, is there science to support some of these gender-based differences? And the thing I find fascinating about MPNs is the answer to this is overwhelmingly yes. There are a lot of differences and a lot of science. Okay, so there's a lot of science in everything, and I spoke about this in North Carolina. So there's actually differences in many different things between men and women. And an example I find interesting is actually preferences between many different things. So a great example is Pepsi versus Coke. So I personally prefer Coke products, but you can see that based on where you live, if you're male or female, there are differences as to what people prefer. And some interesting North Carolina trivia, and if any of you were not aware, so Pepsi was actually invented in the state of North Carolina, which I did not know, was New Bern, North Carolina, small town. And the word Pepsi comes from dyspepsia. So it was initially developed to treat reflux and peptic acid disease. So fun fact for the morning. All right, so let's dive a little bit into the science and talk about MPNs and the science behind this. So when we think about MPNs, we think about the classic MPNs, right? So PV, ET, and primary myelofibrosis. And we know that MPNs are bone marrow disorders of hematopoietic stem cells, and that's important as we start to think about the gender differences, okay? So these diseases are classified and characterized by acquisition of driver mutations, okay? Let's see. So what's a driver mutation? And when we talk about mutations in MPNs, what do we mean? So you can see in the red bubble, there are 3 classic driver mutations that are typically found in MPN patients. So JAK2, MPL or MPL mutations, and then CALR or calreticulin mutations. So those are our classic driver mutations, okay? Then we have the mutations located in the blue bubble. And so those are what we refer to as somatic mutations or additional somatic mutations. So these are mutations that occur in patients that don't necessarily drive disease, but that we see frequently as the disease develops, as it progresses, or as people move through the process. And why are these important? Well, they're important because they impact the disease. We'll talk about some of the gender differences, but they're also important because they impact how patients do, okay? And so I want you to keep that in mind as we're talking about the differences between men and women moving forward. So you see up here, this is an example of a scoring system, and this is a particular one that we use for patients with myelofibrosis. And you can see, we won't go through this in detail, but the point I wanted to make is that if you look at the scoring system, the system we use to assign risks to patients, to figure out how people are going to do, we actually utilize high molecular risk mutations or molecular risk. And so these somatic mutations are important for patients as we think about various aspects of their MPN. Okay, so as we said before, MPNs are bone marrow disorders. They are disorders of stem cells characterized by the acquisition of these driver mutations. And based on some recent data, we think that they arise in the long-term stem cell compartment. So what does that mean? It means that a lot of patients likely have a long precursor state of disease. And we've seen this in various recent publications, which I think is very interesting. So a lot of folks will develop some of these mutations, driver mutations, other mutations, and will have them for longer periods of time before manifesting phenotypes of disease. And so you can see this really nice picture on the right side of the screen over there, which shows the disease progression or an example of progression of these diseases. So patients develop a mutation, they go on to develop a pre-MPN stage, which ultimately manifests perhaps as ET or PV. This can progress to the development of fibrosis and then ultimately on to acute leukemias. And what I find fascinating is that there's a whole host of different things that we believe likely contribute to this progression. So genetic alterations, inflammation, which is a really interesting component of the disease, age, comorbidities, and then I would make the argument that gender is also important within this progression. Okay, so let's talk a little bit about gender and how it influences epidemiology of MPNs, okay? So the incidence of MPNs we know, when you look at all of them together, is roughly gender balanced. But is it really gender balanced? So if you look at the occurrence of each different type of MPN, you'll see that that incidence and the prevalence of the disease changes based on gender. So perhaps more male patients have PV, more women tend to have ET, and if you look at myelofibrosis, that tends to be more balanced. But there is some discrepancy between ET and PV in terms of gender distribution, okay? So we know that the prevalence of MPNs, the overall prevalence, is higher in women compared to men. Well, why is that? Well, it's largely because women tend to have more ET, and patients with ET tend to have longer life expectancies, and so the prevalence of disease tends to be higher, okay? So we know that the gender has an impact on MPN epidemiology. All right, well, how about MPN disease presentation, outcomes? Are they influenced by gender? And I would say the answer is yes, and there's lots of data to support this, and I think Dr. Michaels introduced this idea already. So we know that male sex or gender is an independent risk factor for worse clinical outcomes, okay? So why is that? Well, a large part of this has actually been attributed to increased genomic instability. All right, what does that mean? Well, remember those driver versus somatic mutations we talked about? It goes back to that. So men tend to have an increased risk of developing some of those higher risk mutations, developing more mutations as they move through the course of their disease, which increases their risk overall of having worse outcomes. So something that we've thought a lot about, something we've learned a lot about. You can also see in the diagram listed on the right there that women, as we saw before, tend to have more JAK2 positive disease and that mutation. And so women tend to have more clonal stability. So as the disease progresses, they maintain one mutation as opposed to developing multiple mutations, again, which leads to overall better outcomes in women. All right, so why does this happen? So to put it in very simplistic terms, it's always better to have more. So I think of that from my own perspective of a lot of different things, but if you've got 2 copies of something, let's say like an X chromosome, it's actually easier to hide problems. And so that's a very simplistic way of thinking about this, but very applicable. So men obviously have 1 copy of an X chromosome and 1 copy of a Y chromosome. Women have 2 X chromosomes. And so the argument and the science behind this would be to say that oftentimes 1 copy of the X chromosome is deactivated or hidden in the course of development. And so if there's a problem with 1 copy of your X chromosome, if there's an issue, biologically and the body can inactivate or deactivate that particular copy of the X chromosome. So women have the ability to do that. Obviously, we don't make that choice. It just happens naturally. But it's a lot harder to hide things when you have 1 X and 1 Y. And so there's also science to support this, and looking at the different types of X-linked mutations that go in and the X-linked genes that are involved in heme malignancies, and we see that many of the mutations, many of the genes that are involved in the development of blood cancers and MPNs are located on the X chromosome. So women who have 2 copies of the X chromosome may be able to hide or deactivate some of those genes that have problems, whereas men don't have that same opportunity. So there is science to explain some of these differences that we're seeing as the disease moves on. All right, so this was already discussed a little bit, which is great, but gender also seems to impact the clinical presentation of MPNs. So we know that both men and women with MPNs are at increased risk of thrombosis. We know that's true across the board. We do also know that men are more likely to have cardiovascular complications of disease in their clinical presentations, and they're more likely to have peripheral thromboses, so DVTs, clots that are in the periphery. Women, on the other hand, tend to be at increased risk of thrombosis in the abdominal vasculature. So that's a difference in clinical presentations. These are things like splanchnic vein thromboses, hepatic vein thromboses. I'll give you an example of the differences in how patients may present. So let's look at women with PV. So if you look at a lot of epidemiologic studies, we know that women tend to be younger at diagnosis in comparison to men, specifically with PV. Patients with PV tend to have a lower JAK2 allele burden, so a lower mutational burden of that specific JAK2 gene at diagnosis. like we've said before, decreased risk of some of those higher risk mutations that can develop or be present. Women tend to evolve from ET to PV, so a lot of folks will start out with an isolated elevation of platelets, and over time, as you kind of think back to the thought of MPNs as a progression, they tend to develop more from ET into a more PV-like picture, and women, again, have some differences in terms of their spleen size at presentation. And so there are some differences looking at gender and how patients present with these diseases. So I go back to this initial slide. Again, as we think about MPNs as diseases, what's leading to the progression through this spectrum, what's impacting this, again, I would make the argument that gender plays a role in this progression. And this leads us to the questions and to the idea of whether or not we should be considering gender as we think about MPN management. And I think the answer is globally going to be yes. I think there's a lot more research that needs to be done to really further define and help us figure out how to get to those specific answers. So things we should be considering. So should we be intervening earlier in men versus women? So if we think that there's a long precursor state of disease, is that more common in women or men, and should we intervene earlier? Does this impact our choice of management? And then we talk about these higher risk mutations. Should we be monitoring, let's say, men more frequently with mutational testing if we know that they're at increased risk of developing additional somatic mutations? So all questions that are being asked and brought up, lots more research to be done to do that. So if you think about MPNs, and obviously this is what we're talking about, we've been talking about the classical MPNs, but I put this slide up to show that the gender differences extend beyond classic MPNs into other non-classical MPNs as well. So another disease I treat in clinic is something called systemic mastocytosis. I see a lot of these patients. This is a disease of mast cells, so another abnormal bone marrow cell, which is driven by a particular mutation. You can see a very pretty mast cell on the right. And within this group of diseases as well, you see gender differences in terms of clinical presentations, in terms of outcomes. You can see the nice survival curves here. So this was a registry study looking at over 3,400 patients with systemic mastocytosis. And again, in this patient population, male gender tended to be associated with worse outcomes and an increased risk of developing higher risk mutations. So there is science to support these differences within MPNs, including both classic and non-classic diseases. All right, so we talked a little bit about the science behind this, about the biology behind it. So let's talk about symptoms, because that is one of the most common things that I deal with every day in clinic, right? How do people feel? What do we talk about when people come to clinic? So we know that women in general tend to describe more numerous and more intense symptoms in general, and this is independent of location of these symptoms, organ system involved, the whole 9 yards, okay? And so what I find fascinating is that this really spans the spectrum of everybody, women in general. So this is a really interesting study. This is from 1993, so this is not new data. This is, in fact, very old data, and I usually don't quote old data, but this study was phenomenal. So they took 13,000 patients. That's a huge study. Took 13,000 patients, and in this particular study, they were looking at symptoms that patients reported and symptoms that were important for primary care, and they wanted to see if men and women reported symptoms differently. And so 13,000 people filled out surveys. It was this diagnostic interview schedule survey, validated tool. This particular survey asks about 38 symptoms for people to describe 38 symptoms over the course of their lifetime, and with this particular study, they looked at 26, okay? So what they found when people reported symptoms based on this survey is that gender had a major effect on the prevalence of symptoms. So of the 22 non-menstrual complaints, obviously 4 were only applicable to women, 20 of the symptoms were more common in women. So these are in people. These are not in patients. These are people in a community taking a survey who were not necessarily patients. And so we found, again, 20 of the symptoms out of 26 were more commonly reported in women. So this happens in non-patient populations. We also know that women report more symptoms and have more severe symptoms based on data done in global oncology studies, okay? So this was a really interesting study looking, again, very large number of patients, so 24,000 patients who had participated in a SWOG or a cooperative group clinical trial. So this particular group of investigators pooled all the data, all the adverse events, all the symptom, all these events that happened as part of clinical trials, and looked at whether or not adverse events were more common in men versus women. And so these patients were global cancer patients. They were getting chemotherapy, immune therapies, targeted therapies, any type of therapy. And when you looked at these adverse events, they found that women had a 34% increased risk of having a severe adverse event compared to men. That's pretty impressive. So in cancer treatment in general, women tend to have more adverse events and more serious adverse events. And I think the interesting point to take home is that we see this, and this holds true for patients with MPNs. So Holly Geyer, who I actually went to medical school with back in the day in North Dakota, and Dr. Mesa did this lovely study, a retrospective review looking at a prospective study looking at 2006 patients and how patients reported symptoms. And these were patients with MPNs, so ET, PV, and myelofibrosis, so all types of MPNs. So patients filled out 2 surveys, symptom report surveys, so the MPN SAF, which Dr. Michaels discussed, so a known symptom outcome score for patients, and another survey called the British Fatigue Inventory. So based on these 2 surveys and how people reported their outcomes, we found that women reported more severe and more frequent symptoms, both globally, when you look at the total symptom scores, and then even for each individual symptom that was queried. Okay, so you can see the difference in the MPN SAF total score, indicated by the blue arrow comparing men versus women. And then if you look at the individual symptoms queried, we saw again that women reported more severe symptoms, really in a majority of the symptoms that we thought about. It's also interesting that women tend to report more abdominal symptoms, so more abdominal pain, early satiety, and more microvascular symptoms in comparison to men, so headaches, night sweats, those types of things, and that was consistent. Interestingly, and what I find most interesting, is that when you looked at the overall quality of life that patients reported, even though women reported so many more symptoms, more severe symptoms, the overall quality of life scores were the exact same. So lots of reasons why that could be the case. And everybody's shaking their head out there, and I could come up with a few hypotheses, but there's no science to support the reason here, but we can always make some guesses as to why this may be. So very interesting. All right, and so let's talk just a little bit about clinical trials, because we've had a really lovely talk about that already. So when we're thinking about symptoms, we know women have more severe symptoms, they report more symptoms. How does this impact treatment? How does this impact clinical trial participation? What happens? Well, this is something we don't always think about, but women are actually more likely to participate in these patient-reported outcome surveys. So we find, when we look at clinical trials and when we do studies, that a disproportionate number of females participate in the surveys. So, like we said before, MPNs are generally gender balanced, right? But we do find that when we look at survey completion, as high as 4-to-1 male to female ratios exist when we look at who completes these surveys. So women, again, report more symptoms, have more severe symptoms, and they tend to participate more in these surveys. So this is important, and it's something we really think about and should be thinking about as we're moving through clinical trials and as we're enrolling patients and as we're treating patients in the clinic. All right, so I'm gonna talk just a little bit about the questions that we ask and just kind of whet your palate, because I know there's a lot of talks coming up about things that we want to think about that are gender differences. So asking the right questions, gender-specific considerations. So what's the correct target for men and women, let's say in PV? Dr. Reeves will talk more about this in much more detail, but this is an important question, and this is the difference, and why is this the difference between men and women? So you'll see all the reasons why patients with MPNs and PV have complications, and one of them is thrombosis. We know that if we lower the hemoglobin hematocrit, that decreases the risk. So why is there a difference in target between hemoglobin hematocrit that we sometimes see? Well, it's interesting that when you actually look at the diagnosis, and to make a diagnosis, hemoglobin and hematocrit are part of the diagnostic criteria, and they're not the same. So there's a difference there at baseline when we look at the diagnosis of PV. So why is the target different? All right, well, the target of a hematocrit of less than 45 was based on the ECLAP study, so 365 patients with PV. They were randomized to either be in a high hematocrit group or a low hematocrit group, so hematocrit being high of 45 to 50 and low hematocrit of less than 45. and patients were treated with phlebotomy, aspirin, hydroxyurea, whatever intervention was indicated. And if you look, you can see that there's a clear difference in the rate of thrombotic events when you compare the two groups. So when patients come to clinic, and when women come to clinic and they say, I'm seeing my local doctor, we're aiming for a hematocrit of 42. Why is there a difference? The data says 45. Well, if you think about women in general, again, not necessarily women with MPNs, we know that red cell mass in women in general is about 600 mLs lower than it is in men. And so that's independent of MPN status, that's just baseline. And so the thought is, at least in part, that perhaps women are used to having a lower blood volume at baseline, and they feel better in general when we aim for lower hemoglobin and hematocrit values. And so there's some opinion pieces and some data out there to suggest that perhaps, based on consensus guideline, we should be aiming for a lower hemoglobin hematocrit in women to control symptoms. But in terms of the rates of thrombosis and events, there's no definitive data there. All right, just a few more points and then I'll finish up here. So what about birth control for women with MPNs? We'll talk more about this in the talks later this afternoon, but we know that women in the general population have an increased risk of thromboembolic disease. This is increased if you have ET or other MPNs, and you can see some retrospective data there. Lots of recommendations, and there's more talks about this coming later. But in general, from a practice perspective, we try to avoid combination OCPs and look for alternatives that involve progestins or other methods. What about hormone replacement therapy? There'll be an entire talk about this. I find this to be very interesting. So you look at the symptoms of MPNs and the symptoms of menopause, they're the exact same. So how do you distinguish what's menopause, what's MPN? I don't know. But a lot of women will come to my clinic and say, look, my doctor won't give me anything to treat these symptoms. I don't know what it's from, it won't get better, and I can't get anything for it. So the question we get often, and this is a gender-specific question, is can we use HRT? So we know that the estrogens in HRT are about 6-fold lower in comparison to OCPs. There's a lot of risks of hormone replacement therapy. There's a lot of benefits to hormone replacement therapy, and there's a lot of preparations that don't have estrogen in them and that are transdermal or other preps that perhaps don't deliver as much hormone. So controversial topic, and you'll hear a lot more about this, but use of HRT really is individualized to the patient. But I do use it in clinical practice, and that's an ongoing discussion. All right. Last question, and then we'll move through the end. So does having an MPN affect your fertility? I get this question all the time, a very interesting question. And I think the general consensus is that it actually does not affect fertility, so your ability to get pregnant. That being said, we know that females with MPNs tend to have increased pregnancy and complications. And so those are things to think about as you're considering pregnancy and moving through that. So I'm going to skip this slide because we've talked about that already and end with one final thought. So I hope that I've impressed upon you that there are definite gender differences when we think about MPNs, things that we should think about as women as we're treating these patients and things we should consider. This really does involve a team, and a lot more institutions and places are now with specialized clinic, and a lot of people are specializing in various aspects of MPN care. So I would encourage folks, and I do encourage folks, to think about really building a team of specialists that you need for your care. Cardio-oncology, nephrology oncology clinics, endo-oncology, those are all important, and especially with reproductive endocrinologists as well. All right, so a few final thoughts. Gender impacts various aspects of MPN patients and their care. There's gender-specific issues we should consider. As always, consider a team approach. And then, as we heard earlier, there are so many trials now, so many opportunities, so many things to think about, so the future is bright for MPN folks like yourself. And with that, I'll take questions.
Thank you so much. Any questions at this time for Dr.? Yes.
Yes, my question has to do with why do you not see erythromelalgia listed on symptom assessment scoring?
Oh, that is a great question. You mean, why is that not included in the MPN SA?
Yes.
So I think what we often try to do as we're developing these scoring systems is choose the most common symptoms that people have. I think what we've learned, or what I've learned treating these folks, is that everybody has so many different symptoms, and there's so many symptoms associated with these diseases. it would be impossible to include everything in these really focused scoring systems. And so we don't include everything. We try and capture as much as we can as we develop different scoring systems. And they're all a little bit different. Yeah.
Okay. Any other questions at this
Dr.
time?
Michaels as well.
Hang on.
We use the MPN SAF for is to understand how you're doing at time point 1 versus time point 2 versus time point 3. And if you suffer from erythromelalgia, you can just add that on to the bottom of your SAF and just write, my feet have been killing me every time I stand for more than 10 minutes. And I think that's erythromelalgia. So add that on, and then if there's an intervention that undergoes, you do like any of those. The next time you do your MPN SAF, you can write, my erythromelalgia is better. So you can add those different symptoms in, because the MPN SAF is not just to compare you to everybody else, it's to follow you over time.
We sent an interesting survey out about spleen size versus how a patient feels. And I'll share that data sometime, but anyway, it was really interesting.